Right. Okay, let's get started. Hi, everyone. I'm Rubaiyat Haque, one of the allergy consultants from Guy's Hospital. Welcome to the webinar. Apologies, there's been a bit of a hiatus in the webinar program. We were going to present something on the COVID vaccine allergies last month, but it was delayed for various reasons. Hopefully, we'll bring you an extra session at the end of next month, in April. To give you an update on what the COVID vaccine allergy situation is at the moment. So just if you're not familiar, this is a series of webinars that we usually organise once every 2 months, usually on the last Monday of each month. Each webinar is hosted and organised by one of the BSACI Council members. And this month, we've got a really great programme, actually very relevant to all of us, and this is being organised by Tomaz. So I will hand over to Tomaz to introduce the session and get things started.
Thanks very much, Rubaiyat, for inviting me and allowing me to introduce this topic, which is, as you say, close to all of us, really. The avalanche of penicillin allergy heading towards us. And we've got 3 excellent speakers that are very much involved in the field to take us through the burden of this problem, some key solutions, and what's happening with regard to research into addressing the problem. So I hope that that'll be very interesting for everyone. The talks are structured particularly to be relatively short, relevant to the point, and we'd like to then convene our panel for a Q&A session at the end. I would encourage people to ask questions as we go through the chat process, and I will keep a list of the questions and then present them towards the end. So I think without any ado, I'd like to introduce our first speaker, who is TK, a consultant colleague of ours from Birmingham, and basically he is going to introduce the concept of the burden of spurious penicillin allergy. Thank you very much, TK.
So good afternoon, everyone, and thank you, Tomaz, for the invitation. This topic is very close to my heart, and I've been working on penicillin allergy with some of you, as you know, over the last 5 years or so, really. And my task over the next 10 to 15 minutes is to give you an overview of the burden of the problem, i.e. penicillin allergy. But I thought what would be really relevant today would be to set the scene by just touching upon antibiotic usage at a global level, introducing the concept of antimicrobial resistance, and then delving into the burden of penicillin allergy, because I thought that they're so closely interlinked that one cannot ignore the first 2 bits, because as allergists, we are sort of focused more into the specialist aspects of penicillin allergy. And I think we need to really have a holistic view, and that will just give us the impetus to work in a concerted way with our colleagues in other disciplines relevant to antimicrobial stewardship, really. So this is a screenshot from the World Allergy Organization website regarding the AWARE classification. Some of you might be aware of this acronym AWARE, which stands for Access, Watch, and Reserve Group of Antibiotics. So basically, the WHO came up with this classification in 2019 just with an effort to optimize and standardize the use of antibiotics at a global level. So really, when it comes to access antibiotics, they are common antibiotics. There are about 48, I think, if I'm not mistaken, in the WHO database that comes under this category. They're used for common infections, and they've got low resistant potential. That is the main thing here. That's a good examples of penicillins, first generation cephalosporins, and Ceptrin. Now, the second category is the watch group of antibiotics, which have got a higher resistance potential. And good examples are the later generation cephalosporins, quinolones, and macrolides. And the last group is a reserve group. It's a last resort antibiotic that one would usually use for treatment of multiple drug-resistant infections. Good examples are carbapenems and daptomycin and so on. Now, what is interesting is that you would expect that the prescription patterns would be much the same across the globe, but it's not. For example, if you take India, for example, in the Indian subcontinent, the watch group of antibiotics are prescribed more often. And this is all relevant when it comes to antimicrobial resistance. Now, what is also important is that if prompt action is not taken right now, then over the next 30 years, we are going to lose about an estimated 2.4 million lives in Europe, North America, and Australia to antimicrobial resistance. And what is really worrying is that 40 to 60% of infections in some low-income and low-middle-income countries are associated with antimicrobial resistance. And just to give you the state of play in Europe, for example, in 2015 alone, the statistics suggest that over 600,000 infections were associated with antimicrobial resistance. So this is all quite worrying, really. So just to give you a flavor of what's happening at a global level, you can see that when antibiotic usage is standardized as defined daily doses, as per the WHO stratification, there's quite a high use of antibiotics in high-income countries. But what is really worrying is the steep increase that you see in antimicrobial usage in upper middle and lower middle income countries. And you see the trend for the reserve group. There's a rising trend in the use of carbapenems and polymyxins in both high income and low middle income and upper middle income countries. This is not really an ideal situation. Now, this infograph is taken from the SPOR document, which is the English Surveillance Program for Antimicrobial Utilization and Resistance. And what you'd see is during the last 5 years, there's been a steady increase in the rate of invasive bloodstream infection. And what is more worrying is that there's a 30% increase in these BSI or bloodstream infections associated with antimicrobial resistance. So WHO has come up with what is called as the Global Action Plan objective. I'm not going to go into the details of it, but I just want to highlight objective 4, which is focused on optimization of the use of antimicrobial medicines in human and animal health. And I think that's what is, that's where I think, in terms of antimicrobial usage in humans, optimization, that's where we can help as allergists and clinical immunologists. Now, this is a slide taken from the 5-year plan, the UK 5-year plan for tackling antimicrobial resistance. And what I would like to highlight here is the UK government is keen to see a 25% reduction in antibiotic use from 2013 as a baseline, but more importantly, they want to see a 10% reduction in the use of reserve group and the watch group antibiotics in the UK hospitals. So that's where we can help. So essentially, if we can enable use of the access group or the penicillin group of antibiotics by removing penicillin allergy labels, that will automatically mean that we reduce the use of the reserve group and the watch group antibiotics. Now, why is this topic important? I mean, the UK Chief Medical Officer put antimicrobial resistance on the National Risk Register 2 years ago, and the United Nations has highlighted antimicrobial resistance as a high priority item in its 2016 resolution. There have been numerous publications, including landmark papers in JAMA, in the Lancet, highlighting the overdiagnosis of penicillin allergy and what impact it might have on clinical care, antimicrobial resistance, clinical outcomes, and also the costs incurred by health services. This is a fantastic piece of work that's been carried out by our friends in Leeds, Rob West and colleagues, looking at the epidemiology and the impact of penicillin allergy labels on health outcomes. So first of all, I would like to show that they calculated the prevalence as around 6%. And this study was carried out by interrogating health records, electronic health records in about 400 GP practices over a year between the 1st of April 2013 and March 2014. Now, why is this important? Because in the United States, for example, 10% of the US population carries a label of penicillin allergy. Now, in high-income countries, including UK, USA, Australia, etc., there are several studies and audits which have shown that 15 to 20% of inpatients in any given hospital carry a label of penicillin allergy. And why is that important? Because approximately half the patients require antibiotic therapy. So having a penicillin allergy label is a significant impediment in the delivery of antimicrobial stewardship. So what you see in this slide is a systematic review published recently, looking at various studies that employed skin tests to investigate in patients carrying a label of penicillin allergy. And what this study really showed is over 95% of patients reporting penicillin allergy were shown negative on skin testings. And that's exactly what our experience has been in Birmingham. What we did was looked at over 200 patients presenting to our clinic, and we systematically evaluated them as per the BSACI guidelines. We took a good history, and that was followed by skin testing and challenge procedures. We stratified the patients based on clinical history into 4 groups: those where the history is suggestive of a type 1 hypersensitivity reaction, where the history of suggestive of a delayed hypersensitivity reaction, where the clinical history, there are numerous gaps, we labeled that as an indeterminate category, and finally the clinical history is very, very clearly not suggestive of an allergy. So we had 4 groups, and the outcome of our investigations was that in the last 3 groups, over 90% of patients were successfully delabeled. Okay, and in the first group, where the history was suggestive of type 1 hypersensitivity, nearly 75% of patients were successfully delabeled. Overall, more than 90% of patients presenting to our clinic were delabeled as per the BSACI, following the BSACI guidelines for penicillin allergy investigations. Now, just going back to the study by West et al. In Leeds, they looked at clinical outcomes, and what they showed was that when you have a penicillin allergy label, there is a default, prescription of the less preferable broad-spectrum antibiotics, which contribute to antimicrobial resistance. And indeed, they showed that penicillin allergy label led to higher rates of Clostridium difficile and MRSA infection. And most importantly, these patients were also more likely to receive a repeat antibiotic prescription within a month. So that's not really an ideal situation. Another very important landmark study, I would say, again, from the UK database, this was done interrogating the THIN database, again, another primary care database, data collected over 10 years between 1995 to 2015. And this is carried out by Blumenthal and co-workers from Harvard. What they did was they looked at penicillin allergy label patients, and they had 5 control, i.e. non-penicillin allergy, those who did not have penicillin allergy, and they were matched age, gender, and entry time into the records. And their main objective in the study was to look at the impact of penicillin allergy label on MRSA and C. diff. And just as our colleagues from Leeds showed, Blumenthal et al. Also showed that having a penicillin allergy label significantly enhances the risk of MRSA and C. diff infection. And also, they showed that prescription of alternative, less preferable antibiotics was significantly higher in patients with penicillin allergy group, thereby leading to higher healthcare costs because these antibiotics are more expensive. So we in Birmingham did another study that was published a couple of years ago, looking at the impact of penicillin allergy labels on management of sepsis. So what we showed here was we looked at 50 patients with penicillin allergy and 50 patients with no penicillin allergy labels. They were all matched for age and gender. And what we showed was the total antibiotic burden in patients with penicillin allergy was significantly higher, and that translated to higher treatment costs in patients with penicillin allergy by several fold. And what is also terribly important was we showed that there was a significant delay in the prompt administration of antibiotic therapy as a part of sepsis management guidelines. So we all know that how important it is to get the first dose of antibiotic in that patient presenting with sepsis. And we found that about 16% of patients, there's a significant delay in administration of antibiotic therapy relating to their penicillin allergy label. And what you can see on the slide here also is that patients with penicillin allergy labels had higher rates of prescription of carbapenems, quinolones, and other less preferable antibiotics. So from a surgical viewpoint, Blumenthal and co-workers looked at the impact of penicillin allergy label on surgical site infections. We all know that antibiotics are administered prophylactically prior to surgery. And like in other studies, showed that there were higher rates of prescription of clindamycin, vancomycin, and gentamicin in these patients preoperatively. And that was directly related to higher rate of surgical site infections. And in fact, they showed that there was about a 50% higher chance of developing a surgical site infection as a consequence of penicillin allergy label. So this was about 7 or 8 years ago. We did a real-time pharmacoeconomic study in Birmingham, in 3 hospitals, in 3 teaching hospitals in Birmingham. What we did was we looked at over 100 patients and we interviewed them on the wards whilst they were in patients with a structured clinical history. And essentially what we showed in the study was direct delabeling could be carried out in approximately 40% of patients. And then we did pharmacoeconomic evaluation and showed that in 3 hospitals, excluding overhead costs, the excess antibiotic costs for alternative antibiotics that were prescribed in these patients was something between 250 to 500,000 pounds each year. Now, I leave you to imagine what the cost will be for the rest of the NHS, and then if you add the overhead expenditure to it, it will be in the order of several million pounds sterling each year, and that's exactly what our colleagues in US have also estimated in Partner Health Group of hospitals in Boston. So really, in summary, I hope I've shown you some evidence here that there is indeed a huge burden of spurious penicillin allergy in UK and other high-income countries. Penicillin allergy labels are a significant impediment to the delivery of antimicrobial stewardship. Penicillin allergy labels enhance the risk of antimicrobial resistance, hospital-acquired infections such as Clostridium difficile, as well as surgical site infections. They can delay the treatment of sepsis, and they can lead to substantially high healthcare costs in the order of several billion pounds each year. And there's an urgent need for a safe, feasible, and pragmatic approach to penicillin allergy delabeling, both in primary and secondary care. And that's exactly what my colleagues Shuayb and Louise are going to talk about now. Given this burden, what are the strategies that we can put together to help our colleagues in infection and microbiology to deliver a strong antimicrobial stewardship, and we can all, as allergists and immunologists, then contribute in the long-term objective of reducing the burden of antimicrobial resistance, not just in the UK, but at a globally. Thank you very much indeed.
Thank you very much, TK, for an excellent introduction to the topic, focusing on exactly where we currently stand and what those risks are. And also thank you for partially doing the next introduction of the next speakers, which takes a little bit of burden off me. I'd just like to remind everyone, any questions, pop in the box and we will invite our speakers back to a panel at the end to address questions at that time. So without further ado, I'll take on from TK's introduction to Shuayb, who's going to talk about some of the potential solutions towards working towards a delabeling structure. Shuayb, thank you.
Thank you ever so much for having me today. So my name is Shuayb. I'm immunologist up north in Manchester. Now we appreciate the impact and the burden of this penicillin and antibiotic allergies upon patients, doctors, hospitals, and communities. So the main problem I see, how can we implement a safe decision support tool that we can delabel these patients with inaccurate penicillin allergy? So given the limited numbers of our services in the United Kingdom, the allergist and immunology services, I see the way forward is to empower non-allergists, non-immunologists to actually champion this process. So in the next 10 minutes or so, I would like to share with you our experience in Manchester of developing and validating a drug allergy app as a decision support tool, so to serve this purpose. And it took only 4 years to actually come here. So it's a bit of a journey. So try to summarize as I can go through that. Now, this is kind of an overall view of how did we do that. Going back, the story started in 2017 when we started with the quality improvement projects. And the aim of this project is to improve the accuracy of drug allergy diagnosis and antimicrobial prescribing in patients with a label of penicillin allergy. So as part of this quality improvement project, we carried on audits and surveys for medical and non-medical prescribers to identify the barriers to best practice and also the possible solution we can offer. As we're going to hear shortly from Louise with regards to the world processes and the successful attempts across the world to establish risk stratification pathway, we know there's approximately now 25 to 30% of these patients with a label of penicillin allergy can be delabeled based on the history alone, without the need for allergy tests. And that's why we developed this decision support tool. So I'm gonna take you briefly through what we did, putting this kind of objectives and aim on the background. So we start with this kind of a baseline audit, which is well established now from the TK talk across the world. You've got poor documentation across medical wards. What as well kind of highlight here, you've got a third of these patients has been labeled as penicillin allergy. They've got intolerance more than anything else. So what we did, we started with the survey for all the medical and non-medical prescribers in Manchester. So we sent a survey around 1,500 doctors and physicians and prescribers, including a specialist nurse and pharmacists in Manchester. Now, the survey, the take-up around 11%, so 164 have actually answered the question. And the main aim of the survey is to investigate the knowledge of these prescribers of penicillin allergy diagnosis and management. So their views about barriers to correct management and improvement intervention that we can do. The high kind of highlights here, you can see the high number of the prescriber agreeing that it's not possible to draw a firm conclusion from the history. And even more worrying, you've got more than 60% here, regardless of the detail of the history, they always agree with the statement that it's better to play it safe. So they don't want to actually prescribe any other beta-lactam related, they just go for alternative. And that's the main problem, as we already described. So then we ask them what intervention we can do. So the top two we got from them is educational session, which we all do. And then they would like some sort of an interactive questionnaire or decision support tool that will help them. And nowadays, all these junior doctors in the world, they use app for everything. So we thought maybe the time to actually think about a drug allergy app. So we started with workshops, and this is basically many workshops with junior doctors and senior doctors. So the workshops, generally speaking, around 4 workshops and 200 roughly participants, including foundation doctors, core medical training doctors, consultants, registrars, immunology and allergy consultants and nurses, to kind of get their feedback of what we could do in a drug allergy app format. So we've created this simple 10 questions, and the question literally based on NICE clinical guidance 183 of how we kind of divide and classify the history of penicillin or antibiotic allergy, and we can come with the outcome. So we've gone through the pathway of collecting the data, putting the feedback, creating the wireframes, the design, the visual design, finding out what the patient gonna say, what the doctor gonna kind of get from the patient, and how you're gonna document that. So we went through this process of developing the app, different pages of the app, and that's done by the innovation team in Birmingham City University. Now, these are the questions we've kind of come up after all the feedback we've taken from the junior doctors and the nurses and the consultant. And very simple question, you can see here, all based on yes and no questions, and very basic question to describe the outcome. Here are the main outcomes we come up with. So the main top three outcomes, outcome 1, 2, and 3, these are the classification of drug hypersensitivity reactions according to NICE Clinical Guidance 183. And then you've got the category of the history not suggestive of allergy. And then obviously you're going to have a group of patients where the history is not sufficient to actually classify. Now in the app, you're going to have some sort of a basic recommendation to say where you're going to go from here. Are you going to refer, go ahead and give the antibiotic? So what I would like to share with you is the process of the retrospective validation. Now this has been submitted now to, and hopefully we'll get it published soon so everybody can see the detail further. So just to kind of go through the definitions, which is the main key. So we defined the sensitivity is a proportion of the allergic patients correctly identified by the algorithm, by the app, while sensitivity is a proportion of a non-allergic patient. And now the negative predictive value is the proportion of the algorithm negative cases. So how many of them actually found to be negative? And the same apply here, the proportion of the algorithm positive cases. I hope that's clear. We can go through that in detail in the question. So we've done it retrospectively. So I had a look on 100 patients in the positive arm and 100 patients on the negative arm. So in the positive arm, we had around 46 male and 54 females, and similar number in the negative arm. So the positive arm are the outcome 1, 2, 3, which is type 1, delayed severe and delayed non-severe. And in the negative arm is mainly outcome 4, but we've got outcome 5, which I'm going to explain why in a few minutes. So I'm going to just expand one of these so you can see exactly how we did that. So when we go through the 10 questions through the history, so we take the first attendance of this patient whose diagnosis has definitely been confirmed by a dermatologist is either 10 or SGS or AGIB or DRESS. And this is data over 5 years to actually come with the true diagnosis of these patients. It's pretty difficult to find these patients. So when we gone through the history, all the outcome was delayed severe for patients who had one of these diagnoses, and type 1 for the patient who had confirmed immediate type 1 hypersensitivity reaction. Now, when we come to the negative group, you've got 76, we're unable to classify the history, 17 were type 1, and 4 where the history is not suggestive of allergy. Now, this is important because the group we've done that testing for, the validation for, is the patient who came to the allergy clinic. So is a supreme group of patients. So it's not like in the actual medical assessment unit. So what the outcome? So we've got the sensitivity 100%. So there's no misclassification. And the same for negative predictive value. The specificity around 83% and the positive predictive value of 85%. Now, the main question here with about category 4, and I think that's the question we get all the time, and that's what we're trying to get out. So we recognize, I mean, that patients including this retrospective validation is mainly patient came to allergy clinic, and I think that's the main aim will be for the prospective validation when we start that. So now with this validated drug allergy app in a retrospective validation, what is next? So I feel by empowering this non-immunologist, non-allergist to correctly identify the patient, basically the referral to allergy and immunology will going to increase. That's an inevitable. But then that's only the short term. The long term, we're going to have a lot of cost saving. That's kind of the main thing. And then obviously following that, we need to prospectively validate this app so we can use it in the clinical practice soon. The main limitation, as you may gather from the data, is only being used and validated here in Manchester in a tertiary center receiving referral for dermatology and allergy. So to generalize the data and the use of the data, we need further analysis with that. So I would say in conclusion from this, the survey clearly has shown obvious tendency to adopt an overcautious approach to prescribe alternative beta-lactam in patient-reported penicillin allergy. The clinical algorithm we've created based on NICE showed a lowest risk for misclassification, which is a key. And I think what we need to do is to think about how can we use this in clinical practice, and with prospective validation and collaboration, this can be soon used in clinical practice. I would like to thank all the people who actually, without them, this work would have not seen any light. Thank you very much.
Thank you very much, Shuayb, for walking us through the process of developing an app over many, many years, and the processes that you've gone through to look at validating that app. And I think one of the questions that already come up was about barriers to delabeling, which I think we can come back to a bit later on, but was very interesting to see that some of those barriers to delabeling may simply be us ourselves, as in doctors being resistant to that kind of change. But thank you very much, Shuayb. We'll move on to our next speaker, who is Louise, an anaesthetist based in Leeds, who is doing a lot of work at the moment on penicillin allergy delabeling, and is going to talk to us about the current state of play and where we're going with research. Thanks very much, Louise.
Thanks very much, Tomaz, and thank you very much for the invitation to speak. It's always a great pleasure to speak at BSCI things. So this is just a really quick run through of what research has been done and what the current research field looks like. And I'm really concentrating on the UK because I think that's what's most relevant for us, and not all the findings from other countries will be applicable to us. So for a bit of historical perspective, and really TK has covered this already, but really all the evidence so far looks at, it comprises large observational studies. These are mainly in the USA, more recently in Australia, some in Europe, but all of these studies demonstrate a really clear association with harm and an association with increased costs. The delabeling work that's been done, by and large, these are small cohort studies. And of note, they've got really wide variation in the methodology. So lots of different types of healthcare workers delabeling patients, lots of different risk stratification tools, lots of different approaches. Some are more risk averse, some are less risk averse. Some include direct oral challenge testing. So it's quite hard actually to put all of those together and come up with a really clear consensus, because the methodology is quite varied. So I was thinking when I was writing this about where the big gaps are, and predominantly what we lack, and this isn't just the UK but everywhere, are the large randomized controlled trials which prove beyond doubt the causality of harm. So we've got lots and lots of really solid evidence of association, but there's no definitive proof of causality. There's lots of strong signals about improved patient outcomes, but again, there aren't really any yet completed RCTs showing that. The cost benefits are all assumed or presumed. We don't really have a good, clear health economic argument yet in the UK. And improved antimicrobial stewardship, again, is an assumption. And it's a good assumption. I think we can assume that, but we don't really have any large RCTs proving it. But the area that I think we're really lacking in is the really detailed qualitative work around barriers and enablers to delabeling. So both TK and Shuayb have worked on this and have evidence and have talked about this in their talks, but I think we just need more of it. If this was an easy problem to solve, we would already be delabeling people in all hospitals in the UK using non-allergy specialists, perhaps with a bit of allergy oversight. But there are clearly some really fundamental problems. And I think, as Shuayb alluded to earlier, I think it may be that it's the healthcare workers, it's doctors who are some of the biggest problems to delabeling and to labels staying off. But we really need to explore that in more detail. So clinicaltrials.gov is not a definitive list of all trials in the world going on, but it does give you some indication. And I had a quick look just to see at any delabeling trials that are currently recruiting, and there are 8. I thought there'd be more, I must say, but there are only 8 registered on clinicaltrials.gov. One of those is a large RCT in Nashville in Tennessee. That's about 2,050 patients in a randomized crossover trial, looking at how many patients can be safely delabeled. And the second is Alabama, which TK's mentioned, and I've got a few more bits to talk about with Alabama, which is a study based in Leeds in the UK. The remainder of the studies on this website are all small. I mean, less than 300 patient case control or cohort studies, so not the big RCTs that we perhaps need. So just to talk briefly about Alabama, and TK did mention this, but this is funded with a large NIHR program grant. It's run by John Sando, who's a microbiologist in Leeds. And in this study, they are randomizing primary care patients, not secondary care. These are patients recruited from GP practices, and they're randomized to either be delabeled using a penicillin allergy assessment pathway or to receive usual care. And they've recruited patients who had high antibiotic use in the previous 12 months, who are therefore likely to need antibiotics in the future 12 months. And they'll be performing 12-month follow-up to look at the impact of delabeling on antibiotic use and symptom duration within that year follow-up period. As well as the publication that TK talked about, there's also been some qualitative work already published from this study, really detailed qualitative work around the development of the penicillin allergy delabeling pathway, and taking healthcare worker views and patient views and giving a really detailed analysis of that, which is a really interesting read. I've just referenced it at the bottom there. So, as I mentioned, the studies listed on clinicaltrials.gov is not a definitive list, and I'm very aware that there's lots and lots of other bits of research going on around the UK. Some of it will be funded by NIHR, some of it will be funded through other bodies. But in terms of what's publicly available, that's all I could find. So for the rest of this talk, I'm going to talk about other studies that I'm aware of or involved in. The first of these is called SPACE, and this is again another NIHR funded study which TK and I are leading on. This is a secondary care delabeling study where the delabeling will be performed by either a nurse or a pharmacist, depending on the site, and those non-allergy specialists will have allergist oversight. We're going to select low-risk patients using quite a conservative approach towards what defines low risk, and there is more than one definition of low risk, so that these patients can have a direct oral challenge. And we're looking at a range of specialties to cover both the elective or cold patients, if you like, and acute medical and infectious disease patients as well. So we've got a range of patient groups we're looking at. And the primary outcome is really the acceptability of the pathways that we're going to develop within the three sites that are involved, Oxford, Birmingham and Leeds. And we'll be examining the barriers and the cost effectiveness of it, with a view to develop an NHS-ready pathway that can be rolled out as soon as the study is completed to other sites that have allergy oversight. That's going to start recruiting in, I think, August of this year. The second study I wanted to mention is one that's funded by the National Institute of Academic Anaesthesia and is co-funded by the NIHR, and will be a collaboration with the UK Perioperative Medicine Clinical Trials Network. So as the funding would suggest, this is a study set within the surgical population, and it'll be a large observational study of 30,000 elective surgical patients, looking at these surgical outcomes and how they differ between penicillin allergy patients and patients without a label of penicillin allergy. So we'll primarily be looking at surgical site infection, which we know from work from Kim Blumenthal in the States is a problem in QnA patients. They have a higher rate of surgical site infection, but we're also looking at other complications, so other infective complications and other complications that can arise following surgery, to see if there's any other associations. So again, an observational study, not a large RCT, but hopefully with these numbers we should be able to have some useful insights for the UK surgical population. And finally, in September, I'll be starting a doctoral fellowship with the NIHR with a broad remit of drug safety in surgical patients. So whilst I'm looking at quite a few aspects of allergy in the perioperative setting, and the surgical outcomes work I've just mentioned as part of this, we'll also be looking at perioperative delabeling penicillin allergy patients with a particular focus, again, on the qualitative aspects of this. So which members of the perioperative team might be suitable to help us delabel patients? What do these healthcare workers think about delabeling? What do patients think about the delabeling? It's very likely that surgical patients who have an immediate need for penicillin will have a different view on being delabeled to someone who has a remote need for an antibiotic. So we anticipate high uptake, but we want to really focus on those qualitative aspects and see what the barriers and enablers are to a national programme of surgical patient delabeling. So collectively, what I hope is that all of this work that's being done in the UK will help provide the definitive evidence of improved outcomes after delabeling. I think that's one of the first things that we need. We need to have a body of qualitative work that helps us understand and overcome these barriers, which, as I say, are from both the healthcare workers and from patients, and more definitive evidence of cost benefits of these delabeling programmes. And this will be the key information that we need to give to policymakers within the NHS, who can then start to fund routine delabeling as part of patient care. And I presume there'll be questions for all speakers now, but I'll hand back to Tomaz. Thanks very much.
Thank you very much, Louise. I think that's a very good overview of kind of the state of research art of where we are. And I think there's one of the themes through all of those talks, which is very much about the burden of this problem. Now, there has been a reasonable amount of chat coming through, and I would like to pull together all the speakers, if possible, just to see if we can address some of the comments coming through, some of the questions coming through, and then we can open it up to some of the audience as well if they'd like to ask specific questions that I may not have covered. I think one of the very strong things coming through in the comments and chat box has actually been about kids, and I suppose the first question there, which I'll really put perhaps to TK first, is a question about data or studies focusing on children in the context of penicillin allergy. You know, are we aware of any? I'm happy for Louise to jump in as well if she'd want to. In that arena, are we aware of any studies that would help us understand more about children and penicillin allergy?
Yeah, thanks, Tomaz. There are published studies, mainly from the US. And I know that Nick J has been doing lots of work in Sheffield, and so there's quite a bit of evidence there on the pediatric side regarding penicillin allergy delabeling. Most of these labels, as you know, come from viral exanthematous rashes that occur during antibiotic therapy. So most of these are looking at non-immediate reactions rather than type 1, which is slightly higher proportion in the adults, in my opinion. Yes, so there is evidence available in pediatrics, and it's, I think, very important to look at it both from a pediatric and adult perspective. After all, the patients that we are seeing in the adult population, some of them, you know, the history dates back to childhood. So I think a combined approach is required. Yeah, there is evidence available, and the evidence is very strong that penicillin delabeling is successful.
Yeah, no, thank you very much for that, TK. And one of the other focuses really touches on what you've just said about, you know, the importance of perhaps tackling this in the pediatric setting. And quite a lot of the comments within the chat are, can we have an app for the kids as well, Shuayb?
That's a really good question, isn't it? I think, generally speaking, I mean, the app we're talking about, the broad picture, is this symptoms, is this hives, urticaria? We're thinking about type 1 anaphylaxis, or is that bull-like kind of reaction? Is it delayed severe one, or is not really related, macular rash or something? So I think would be applicable. Obviously, the data which have done the retrospective validation is mainly adult data. Maybe we need to run it as well in a big center, in pediatric center, and then see if that's going to be given the same outcome or need a bit of tweaking. But I think the general approach, because it's very basic app, it's only based on the major classification of drug allergy, which mentioned in NICE guidance. Yeah.
So, I mean, maybe one of the approaches that we could take from this feedback is we need some of our pediatric leaders in this field to stand up as well and perhaps collaborate on working on developing a tool that might work as well in kids. And I was about to move on to something else for Louise, which is basically about BSACI support really for, you know, direct oral challenge, non-specialist delabeling, and where we're up to with that.
Yeah, so I will answer. I just would say very briefly that in terms of the delabeling of people, my concern is always that the delabeling is potentially the straightforward bit. The problem is how you keep the label off. So we know that somewhere between 40 and 50% of the people who've been delabeled will either put the label back on themselves or one of the healthcare workers around them will put it back on. So I think one of the main focuses of work, certainly that I'm interested in, is how we actually keep labels off and stop relabeling. That seems to me one of the bigger problems than the actual process of delabeling, which, you know, does require some standardization and governance issues around it, but perhaps isn't the single biggest problem here. In terms of BSAI support for non-specialists, so there's a writing group currently with BSAI, which is writing guidelines for how non-specialists can safely delabel patients using a direct oral challenge, with the intention, so everybody on that writing group, outside of immunology and allergists, everyone on that writing group is representing their professional stakeholder body. So we have anaesthetics representing there, microbiology, surgery, infectious diseases, medicine, all the specialties who have a stake in this are represented on that writing group. And we are in the process of grading all the evidence in order to write a guideline to the BSACI Standards of Care Committee standards, which we hope will be published later this year. And what that guideline should offer is a framework, a governance framework for non-specialists to delabel. So it'll tell you, you know, which patients you can use, which risk stratification you do, how you actually do the delabeling, what the safety equipment that you need available is, and what level of allergy or immunology oversight is required to do that safely. So I think it should be a template which people can use. But as I say, that in itself is not going to get around the problem of delabeling hesitancy, if you like. It's like vaccine hesitancy, is it? People being anxious about being delabeled and then sticking the label back on. So it's part of the solution, but it's not the whole solution.
And Louise, before this particular question comes up specifically, is will this apply to kids as well? Yes,
absolutely. So Nicola J and Sue Leach are on the writing group, and as somebody mentioned just now, Nicola's done a huge amount of work in delabeling children. Children can be treated in a different way for various reasons with delabeling, and we will have a separate section for pediatrics. Yeah.
Okay, now I think just another comment that I'd actually like perhaps each of you to briefly comment on, which is basically that fundamental point. Let's not put the label there in the first place. It's not only let's not, you know, put the label back on once we've delabeled, it's also stop putting it on in the first place. So how are those labels actually arising in the first place, and how can we intervene to stop them being applied unnecessarily? So TK?
Yeah, thanks, Tomaz. First of all, before I answer that question, in the study that we did about 7 or 8 years ago in Birmingham, 20 to 30% of patients, I can't remember the exact figure, but they had received a recent course of amoxicillin or comoxiclav, and they were still going around telling doctors that you know, they are allergic to penicillin. Now, how are these labels arising? There are multiple reasons for that. I did a study with Claire Bethune a few years ago involving a medical student And we surveyed all the UK medical schools. And very interestingly and worryingly, less than 10% of the medical schools actually offer training in basic allergy history taking. So, there are lots of studies from the US also, highlighting that there are huge gaps in knowledge and skills of healthcare professionals, that's doctors, pharmacists, medical students, nurses, regarding, a good basic history, allergy history taking. And I think, there's also confusion regarding the names of penicillins, actually. So some of the doctors get confused between augmentin, comoxiclav, penicillin, and all that. And I know in my own experience that, a patient received not once, but 2 times augmentin and comoxiclav, despite shouting out that they were allergic to penicillin. So both, it happens both ways. So I think it's about knowledge, it's about training. So it's attitudes and behavior of healthcare professionals, put it that way. And also it's a combination of patient behavior also, just like Louise just highlighted. So there are multiple, I think you need to take a multi-pronged approach, I would say, and that's exactly what we are trying to do in the space study, is, there's a one full package of work that is completely dedicated towards assessment of behavior and attitudes of healthcare professionals and patients. I think it's really crucial to understand that before you put any intervention. Otherwise, there will be very poor uptake of the intervention, be complete waste of time. So I think as you develop your intervention, it's important to make sure that that intervention aligns well with your health service framework. So what works beautifully in Boston may not work in Leeds or in Birmingham, so you got a different type of population here. So I think we just need to carry out studies in our own population before, it's not as easy as simply extrapolating a app from another country.
Okay, thank you. And Shuayb, would you like to add anything on that point?
I think definitely TK covered all the main items, and I would add on. I mean, now currently there is the national education strategy for allergy led by Jude in Southampton, Professor Holloway, and I think this is kind of one of the strategic thinking by BSACI. I mean, helped and supported by BSACI to actually approach this problem. I think the education, as already TK has mentioned clearly, the education is the key, and that's our job, is to actually spread out the word more, educate people via different platforms. And that's one of the main aims of my app, is get this education platform for them as well. All these different pages in the app is to educate these non-specialists just to know a little bit about what these allergies and what the main recommendation we say from the allergy and immunology perspective.
Thank you, Louise. I won't recycle the question completely back around to you.
I mean, I don't really have much to add. I think it's education and knowledge. I have anaesthetic trainees with me all the time, and they'll say things like, well, it can't be the penicillin that patient had an allergy to because they had it 6 months ago and they were fine. Somehow that is still, a cultural norm. So there's a big cultural change that needs to happen. And I think I've thought for a long time that some sort of public awareness campaign would be really useful. There's enough people in the UK affected by this to make it worthwhile doing that, and put a little bit of the onus on patients to start, once we have a system that can facilitate widespread delabeling, then we should really encourage patients to be asking for it. There's no point at the moment because we can't say, if you're a 30-year-old who's fit and well, you won't get tested. But once we have a system where we can delabel everybody who wants it, then we should be encouraging patients to come forward and taking a bit of ownership of that, I think, and that would need a public health campaign.
And that links in quite nicely with what someone has said in the chat box about, how do we persuade our patients that a penicillin allergy label is actually bad for them? And how do we do that kind of public campaign?
Would you know, my experience, and you may all have different views on this, and there'll be people listening with different views, but my experience is that patients aren't the different, they're not the ones to persuade. They're up for it. It's all the people around them who they're too risk averse. I'm not sure they had that test, but I'm just not sure, or I'm not sure I want to refer them, or I don't believe the test. We've had patients who we've been delabeled who've then gone to theatre and the anaesthetist just doesn't believe the validity of an oral challenge test. So I don't think the problem's in that direction. I think it's in the other direction. In
the professional staff.
Exactly.
Okay, so I'm just going to touch on two very brief points, and I'm going to make this open really to whoever wants to take them, and then I think we can potentially wrap up at that stage. So the first point really is about primary care and general electronic systems, and how easy realistically are they in order to change these labels that have been applied. This is a problem that I think we see all the time, is getting these systems updated. How difficult really is it?
I think this problem is funding. Can I just say 2 words about this? I mean, we tried with our GPs here in Manchester, and a lot of them say we can take the D label away sometimes, but then if they took the D label away after we've done the testing, there's no records at all in their system that's the label ever been. And that could be a medical legal thing. And obviously there's an elephant in the room we haven't touched. That's what I want to say.
Okay, and I think changing the systems are quite difficult. Training is coming up as a big thing in the chat. You know, how do we get the training out there? How do we get our specialists, other doctors, GPs, etc.? What level of training do they have? What influence do we have on that? I know that we do provide a reasonable amount of training and educational sessions wherever we can, but the quantity of allergy training within, you know, general medical training, etc., is generally very low, which is manifest by exactly what we've all just been saying.
Yes.
So how do we influence that?
Well, I think the work by Professor Holloway, this is a national BSSI strategy group, they exactly tackling this problem. They divided 3 main themes on primary care and secondary care and community, try to collect all the data, get the stakeholders, and actually get to the bottom of this and to improve and unify the whole pathway. So they're doing a huge work on that perspective. And I think they already published just an overview of the strategy, what they want to do. But again, is a collaborative work. Need a lot of people in this. It can't be just one person doing all.
So just to add to that, Tomaz, you know, Blumenthal et al., they published a review in JAMA, I think it was about 18 months ago or something, quite a comprehensive review where they also advertised their e-tool, which showed a very high uptake in secondary care. And I think they aligned their delabeling program to the electronic tool. So essentially, you know, you would not be able to carry out your delabeling on the ward if you had not gone through the basic training with the electronic tool. And they made the system in such a way that it's embedded into the management plan. And in the space study, we've been mindful of that actually. And Louise, you'll agree with me that you know, one of our secondary objectives there is to come up with a strategy for development of e-tool based on the different things that are going on within the space study, including the qualitative work and including the delabeling. So, you know, we are probably delabeling about nearly 400 patients or so, I don't know the exact number, in different settings in 3 different sites. So hopefully that's going to teach us a lot about where to put the bar, where to put the threshold with delabeling. As Louise said, what means low risk to me may not really be low risk to someone in the States or Australia. They may call it very low risk or they may call it medium risk. So we are not speaking the same language. We are not in the same page. And I'm glad we are not on the same page. We should not be in the same page because it has to be, you know, to a country specific really. So hopefully, you know, at the end of this program of 2 years of research, we will be able to come up with a fit for purpose electronic tool that will synergize this whole idea of penicillin allergy delabeling in secondary care. Now, again, primary care, it's a different ballgame. I think you need to make some subtle alterations there as well. You can't use what you developed in secondary care in primary care. You may have to make some alterations there.
Okay, well, I'm going to come back to each of our speakers now, just for a final comment or thought of the day, a final point. As TK has just spoken, I'll go to Louise first.
I I don't know. I think, you know, this is such a massive problem and it's so thorny. And if it was easy, we'd all be doing it by now. So there's obviously something really difficult in this topic. And I think it's only going to be solved by collaborative research, basically.
So collaborative research will get us out and get us down this slope with the avalanche crashing down on us.
It's like the vaccine development of the COVID problem.
Perfect. And Shuayb, what is your kind of final thought for the day?
I think the final thought I have, I need champions from all different type of acute setting, champions on the shop floor, on the medical assessment unit, on the surgical unit, on anesthetics, and those champions who will be actually helping us to delabel patients on the shop floor, GPs as well, and other community members.
And TK, your final thoughts for the day?
I will use 3 phrases: multi-professional, multi-pronged, PPI.
Perfect. So
PPI stands for patient and public involvement, by the way.
Yep.
Oh, yeah.
So I think that kind of covers the basic messages. We need all of us to work together, to research together, to develop the outcomes and tools. And from my point of view, it's only really to say thank you so much to the 3 of you for the time you've committed and the excellent talks you've provided today, and that you've put up with the questions I've been asking you. But thank you so much for your time. It's really appreciated by myself, particularly by the BSACI. And I'd also like to thank all of the attendees. I didn't keep a total eye on the numbers coming through, but the highest number I saw was somewhere around 160. So I think thank you very much for giving up your time on a Monday afternoon into the evening to join us today. Thank you very much, everyone.